Welcome to the first Ben's Den podcast episode of 2025. With me, joining me live in our headquarters in Orlando, Florida, three very special guests from Cibolo Health: Clint MacKinney, Brittany Sachdeva, and Nathan White. I'll let them introduce themselves and we'll dig into something that's very important for us to discuss.
I'm Clint MacKinney. I am the Chief Medical Officer for Cibolo Health. My background is that I'm a rural family physician and emergency room physician. I've been involved both in research, academics, and in consulting and value-based care for the past 15 years or so. But my real passion professionally has been rural people, places, and providers. So I'm really excited to now work with the garage to deliver on data to be able to actually serve those rural people, places, and providers.
Brittany Sachdeva, I'm the Chief Clinical Officer for Cibolo, nurse by background, and have spent the last couple decades in the chief nursing, chief operating, and quality realms of healthcare.
Nate White, President and CEO of Cibolo. Spent a couple decades like Brittany in a large system that was covering a tremendous amount of rural geography, and so that's my background. And obviously, as we chat a little bit about Cibolo Health, obviously that our mission continues to be all about rural health. So thanks for having us here today.
Thank you so much for taking the time to visit us. And obviously, I think we all understand the importance of this partnership, the importance of the work that you all do, the importance of our role in empowering the work that you all do. Let's talk about timing for a moment, right? I think rural healthcare today is at a crossroads. It's the way I see it. I think there is significant opportunity to empower a new level of affordability and accessibility for rural patients. And since we serve about 46 million patients is the general estimate, I think there's a massive opportunity to solve for that accessibility and affordability and drive value-based care. How do you all see this opportunity for Cibolo, given that there's a new administration that's coming in? There's a lot of hope. There's a lot of excitement around it. How do you see the reality playing out over the next few years for Cibolo and how you can impact rural care in the country?
The issues that challenge rural healthcare have been around for decades.
Right.
So first, our population is older, they are poorer, and they're generally more ill, more chronic disease in rural America. And the very population that needs our country's resources is not getting them. And rural providers, rural practices, rural hospitals haven't had the infrastructure, the resources to be able to deliver value-based care, which is predicated on the triple aim. Value-based care is an opportunity to improve the care we provide, to improve the health of our communities, and lower cost. But that takes experience, it takes infrastructure, it takes expertise that's in short supply in low, under-resourced organizations.
Right.
One of the places where we've really been under-resourced is with data. So at Cibolo Health, Brittany and I are designing our care management strategy with a backbone based on data. So with the garage now we have this opportunity to actually inform our providers to make wiser decisions based on data, not based on what we've done in the past or based on hunches or guesses.
Excellent.
So the only thing that I would add is, we really truly believe that rural settings do primary care best. That is kind of their bread and butter. That's what the community relies on them for. And so anything that we can do at Cibolo to support a under-resourced, to Clint's point, demographic is, that's our mission. And that's why we really slept at the garage. In addition to having data access that we've never been able to get in small settings, we also really like the user interface that the garage has to offer, so it can support efficient use of our very limited resources.
Whether it's the current administration, the last administration, or the administration before that, the notion that somehow there was going to be a significant increase of funds to rural health care is just not realistic, right? And I think the whole thought behind what the work we do is, how do we build a better model to allow sustainability of great work that is happening? If you look and pay attention to rural healthcare, there's a lot of things that they've done historically, either through grant funding or state pilots or CMS pilots, and it could be preventative medicine based, could be primary care based. But when the money runs out, the model falls apart. And so our focus the entire time was, is there a sustainable model out here for rural? they're underpaid. They don't have enough lives to even generate interest for value-based care. And lastly, they lack the financial firepower to invest in the resources necessary. So we knew we needed scale and what we call a collaborative IQ. And this kind of built this idea of can we do a clinically integrated network? Clinically integrated networks aren't new. In my biased opinion, the ones that are out there are typically predicated on a large system and a hub and spoke model. Which only puts more pressure on the rurals. To send all their profitable business to the big system, and it's not a model. So I stole this from John Naylor, our chief strategy officer. He said, what we've created is an inverted hub and spoke. Build that scale out in the rural. Try to change that model, focus on investing locally. I mean, we want to provide as much care locally as possible. And then work, I don't care if it's Medicare or a commercial payer, a large national insurer, or a local regional payer. I mean, just explaining to them the challenges that we face financially, could be fee for service, could be value-based care, you name it. And that's our focus, right? I think, at least mine on my end of the business, is trying to build that model of sustainability. Now, once we build it, we have to deliver, right? We only succeed if we can somehow shape, way, or form,
demonstrate outcomes,
quality, reduce costs, make a difference. We understand the delivery of it, the execution of it doesn't change, but is a better model on which to do that.
And you're absolutely right, Nate. I think CINs have been around, and we work with quite a few of them, but we have not come across anyone exclusively focused on rural care, and Cibolo is distinct from that perspective and at the scale that you guys are operating. And one of the things that we've been working with underserved communities for years, one of the things that we notice is that you can look at what's obvious, chronic illness, like you said, Clint, but there's also this undercurrent of what's not obvious, which is social factors, mental health, and those kind of aspects, right? Is that an opportunity for you all from a Cibolo standpoint to say that, hey, when we create an integrated network, you are then positioning yourself to tackle the undercurrents, to tackle the foundational issues that are causing demand on the system, that the system is struggling to meet? Is that an opportunity? Are you guys seeing that in the work that you do? Or is that something that you're going to use data as your guide to tell you where to focus?
Well, I'll start first, and I think there is great opportunity there. Right now, the payment system doesn't recognize it. So that will be a challenge. So first, we need to be financially stable as an organization, not Cibolo, but as a healthcare organization, rural healthcare organization. And one of the ways, in a unique way, that Cibolo Health is helping to do that, to build on what Nate said, is this concept of independence through interdependence. So I've been pretty lucky to be as an academic or a consultant in well over 100 rural hospitals. And in most of those, there's this overarching drive to remain independent. And I kind of thought to myself, now, independent isn't really a mission statement, but if you change it just a little bit, is we want to have control of our destiny. We want to have impact on the future of the health in our community. So how do you do that when we need the scale, when we need the volume to participate in these value-based contracts? Well, you join a system. And nobody really wanted that because that's giving away the keys to your house. So instead, what we found with Nate's model is that we can work together as independents, so nobody's giving away the keys, as independents, but we're now able to develop the scale necessary to participate effectively in these value-based care contracts. Again, fueled by, the fuel that drives this is the data that the garage is going to provide us.
I love what you said, Clint. Independence through interdependence. That's really resonates. I mean, that's pretty much what is kind of like the philosophy or the core culture of a CIN, right? I mean, you're coming together so you can stay and automate and basically operate independently and see the patients that you want to see.
And that's unique. That's unique. Nate said CINs, not a dime a dozen, but they're very, very common. They've been around for a long, long time. But there's very few models like Cibolo in this country which are bringing together independent healthcare organizations, hospitals, clinics, maybe even independent practices, to be able to work together to develop that scale and that infrastructure to participate successfully and then deliver on the triple aim.
Nate, do you see the payers resonate with that vision, or are they hands off?
I would say, every payer is
different in the market, yeah.
No
Right.
question. And I think, what we certainly haven't seen any sort of hostile behavior,
Sure.
By
Sure.
any stretch of the imagination. But I would say it does take time for us to for them to get comfortable with what we're doing. It's new. They haven't seen it before, right? And we're perfectly fine for that. We know that this has to be a value prop for the payer and us.
Right.
Right?
Right.
That we, at the end of the day, do have the same mission, right?
Right,
To provide
right.
good quality care at a reasonable price.
Right.
They can't do it alone, and we can't do it alone.
Right.
We need each other. Same goes for the larger systems.
True,
You know,
true.
I say this all the time. Our model is not anti-payer, anti-system. It's pro-rural.
It's pro-patient.
Right?
Yeah.
And just like we don't think large systems are anti-rural
Right.
for their strategies,
Right.
we would never suggest that.
Right.
We're not anti-system.
Right.
The model, I have to keep talking about the model, has to work for everybody.
100%.
And if you think about the payers, right, what can we deliver for them? Well, we can deliver a unified, consistent platform for multiple hospitals.
Right.
If they had to go out and try to manage all that, first of all, they probably wouldn't get invited in.
Right. True.
And second, so there's a tremendous value prop on just getting organized on our behalf for them,
Right.
and we know we have to deliver.
Right.
There's no question.
Right.
And similarly with the systems, there's a limit to what the rural independent providers can do. Right. The subspecialty care is most appropriately occurring at some of the larger systems. Our patients in our communities rely on that.
Right.
It'd be foolish for us to try to pick an unnecessary fight or even suggest that.
Brittany, I want to come to you to kind of get your perspective on the patient's experience and how the patients look at what's in it for them. But Nate touched on something that I want to seep into our technology and data, the role that tech and data plays in enabling the success of CINs. I think Cibolo is going to be the kind of like the benchmark, is the way I see it in the next few years on how to enable value-driven care in rural areas at scale. What role does tech and data play from your perspective? And let's distance the garage for a moment, right? If you had to kind of like look at the next 5 years and you say, this is where Cibolo, this is our mission to be by 2030, what role does tech and data play to get you there?
Well, we believe, ancillary to the garage, that data is the backbone of our care management infrastructure. So without having a really good understanding of how we're performing internally, as well as how our referral partners are performing in terms of cost and quality, we are directionless.
Yes.
Does make sense.
I think the model wouldn't, and I'm not a tech person, right?
Sure.
Like, I can use a phone, stuff like that. I think these technology platforms that have advanced, Clint says this all the time, a lot of the things we're doing weren't possible just a few years ago.
True.
And-
Speed of light.
Yeah,
Yes.
and so I don't care if you're talking about what are the requirements to be a CIN, right? Physician engagement, accountability, measurement, how do you, all of our members have a different EMR.
Yeah.
They all have, how do you possibly
Bring them all
do
together,
this
yeah.
without something like the garage? I think there's advancements in telehealth. I think
Yeah.
there's advancements in data analytics on
Yeah.
the cost of care happening
Yeah.
nationally. And I think you can have a great idea at the wrong time, and
Yeah.
it equals a bad idea.
Yeah.
You can have an okay idea,
Yeah.
like ours, at a really great time,
Right.
and it turns out to be a great idea.
Right.
And I think that's what we kind of see playing out.
Right. And that's the opportunity for us from a garage perspective. We look at this as this is an area that has not seen the deployment of great technology or access to real-time data, right? And if we can use that to empower right decision at the right time for the right patients and
Yeah.
by the right people, that's pretty much how we come at this. Really, from a patient's perspective, I'm curious. Everything that Cibolo has defined, working on, enabling care management, how do you see their day-to-day life changing? Like, for example, if I need to schedule a primary care visit, I'm in a rural area, what is my lead time? Am I waiting for months?
No.
So what are we looking at?
No, again, I think that rural does primary care best. These providers are available and accessible. They want to be able to see their patients. So as far as what's Cibolo's impact on patient care, I don't think that there is one. Our role is to really support these rural entities in being the face of care management, enabling them with the technology and the resources so that when patients do need to see their provider or their care team, that they're available and accessible. And that they have information about how to best care for those patients and meet their needs in the moment.
Clint, did you have a
I
point
was
of view?
going to say that I
Yeah.
know that the garage and words that you've used, you've used the quintuple aim as part.
Yeah.
So let me concentrate on the fourth thing for a
Sure.
second.
Sure.
So Brittany said we do primary care really well, but that doesn't mean it can't be better.
Yeah.
It can be more efficient.
Right.
It can be more effective.
Right.
So you asked a moment ago, what should this look like? What will it look like
Right.
5 years from now?
Yeah.
Well, one of the things we've always been concerned about in rural healthcare is that we're 5 years behind
Right.
the rest. So what we would like to be able to say is, how do we bring cutting edge technology to rural providers who have never had it before, with the sole intent of making their practices more efficient, more effective, so they can rediscover the joy of medicine. So how do we do that? A physician, a nurse practitioner, a physician assistant will be joyful when he or she is able to see their patients getting healthier, when they can see them on time, when their practice is running efficiently, when they're not spending their time doing things like checking boxes or documenting things that machines can do probably better, that leaves the provider available for developing relationships,
Right.
for designing complex treatment plans,
Right.
for understanding a difficult diagnostic dilemma.
Right.
That's where you want the brain power of your providers to be, not trying to figure out their most recent EHR fix. So I think we can make great strides in that, and I think our job has to be that urban is no longer the trendsetter here. Why can't we be the trendsetter as well too, since Brittany just said we do primary care as well as anybody.
Excellent. So that's kind of where my thought process was, to say, the care models that have been most effective are the ones that are, you design it around the patient, right? So the patient is in the driver's seat, but you're using the population or the community facing strategy to basically engage the patient the right way and keep the data ahead of the patient. For example, patient goes from point A to point B, the data should not lag that patient. The data should lead the patient, so by the time patient gets to point B, that patient's data is already there, waiting for that patient. You know what I'm saying? So that applies more in a rural setting from my perspective, and I think that's the another huge way the architecture can come in.
Sure.
and basically fundamentally transform. Let's quickly talk about AI. There's a lot of buzz around AI, and it's some noise, but there is definitely potential in the technology. We are harnessing it in a very applied sense. For us, the A in AI is applied intelligence. That's the way we come at it, whether it is machine learning or natural language, or whatever you call it. How does it get applied in healthcare? And that's what matters, right? How do you guys look at the buzz around AI? Is that something that you have a pulse on? Is that something that you think will empower a new era of access?
I think AI is going to fundamentally change how we work
Right.
in almost every industry. Don't
Right.
deny that. I'm not going to tell you how long it's going to take, but it's here. I've always told my team, I don't necessarily think it's a competitive differentiator. Everyone's going to do it.
Right.
It's like, I have an iPhone.
Right.
Everyone has a
Right.
smartphone.
Right.
So I think it's here. I
Right.
think we have to be very smart about how and when we deploy
Apply it,
it,
yep.
apply it,
Right.
as your term suggests. But it's already impacting things like documentation, your ability to how we code, all those things that are really, really important. There's no question about that.
I think in the short term, it will be a differentiator if you don't have it.
For sure.
If you're not using it. So I don't know where it's going to be helpful. I don't know the difference between artificial intelligence and machine learning. But what I do know is there's a lot of things, day-to-day practice for a rural family doc that is the same for every patient.
That can be
same
automated.
every day of the week. That can be systematized. That can be automatized.
100%.
And let's take that burden off them.
Practice, yeah.
Again, for more efficiency and effectiveness, and we will then have a recruitment advantage
Yeah.
when we're able to do that again,
Yeah.
to bring that joy back to medicine. Brittany, I will be participating in a learning collaborative sponsored by the American Medical Association, specifically around AI applications. That's coming up shortly, so we hope to continue to learn, and we'll always be learning from you and your team.
The only thing that I would add is that we've really gone at AI, our approach to AI is that fourth aim. How can it support providers and care team members, not replace face-to-face human interaction?
In fact, I'd say just the opposite. I think what it does is when that burden of systematized medicine is taken away from them, there's more time for that relationship building, more time for that face-to-face.
And that's kind of how we come at this as well, is that if you're going to create an architecture, right, that is, we want to harness digital technologies like telemedicine, for example. We want the entire experience to be data first, right? We want the scale to be platform based, because there's not going to be enough care managers you can hire in the country to contact every patient. But the entire architecture has to be human centric.
Yeah.
Healthcare is, and will always be human centric. You cannot, come at it saying I'm going to replace that sanctity of that physician-patient relationship.
That's where the value
right?
is.
And
that relationship is where the value is.
Correct. So, thank you for joining me on this short podcast. But the most difficult question is coming up next. You guys ready? I was just giving you softballs until now. Here it comes. Okay. Fun question, right? So all of you answer separately. So the fun question for this episode: if you could swap your life with anyone living, obviously living, you can't swap with someone dead, who would that be and why? You can swap your life with whoever you want to swap with.
Can I just say Clint? I mean,
absolutely. That's easy. That's easy. Who would it be and why?
I'm absolutely no interest in switching my life with anyone. Zero.
That's the right answer.
That's the right answer. That's the right answer.
Of course, I wasn't creative enough to think of that.
That's
but I love
not
that answer. But you know what I would really like, other than being a rock star. Other than that, I would love, if I were 40 years younger, to be a National Geographic funded explorer.
Oh, wow.
I would love to. Or
do you have someone in mind that you...
No, I don't know. Remember Thor Heyerdahl? Remember those guys back?
Yeah.
You just want to crawl around with the lions and stuff?
Yeah.
Oh, nice. That's interesting.
Yeah.
Nate, are you going to stick to Clint, or are you going to... Now that he's...
Other than Clint. No, I wouldn't say anybody specifically.
Okay.
Maybe it's because I grew up the son of a basketball coach. But the people that I admire or would switch careers with maybe it's a coach, all different. I don't even care the sport, right? But their ability to lead and impact change, I think, is just so amazing. There hasn't been a new play invented in football in 50 years, right? Or basketball. They're all predicated on the same concepts. But unique leaders have the ability to put that together, build teams, and win.
Excellent.
Same goes with CEOs. There's tons of CEOs out there that I think are just absolutely phenomenal, that they're able to lead and make good decisions. And I love to watch people like that, and if I could switch with one of them, I'd do it, right?
Excellent.
Excellent.
All right, thank you.
No. We'd like to hear yours.
Yeah.
Who would I swap my life with? My mother, probably. Yeah, I was a pain in the butt to raise, so I would really want to swap my life with her. No, she's been my inspiration, and she had to sacrifice a lot to raise us, in India and whatnot. So just to get into that mindset to do whatever it takes, like I've seen her sell her clothes to pay for our tuition, do whatever it takes to raise 3 kids. So that grit, I would love to experience that. So my mom would be the one I would swap with. Yeah. Anyway, thank you, everyone. Thank you for being part of the first episode of Benston for 2025. Truly appreciate your time. Thank you.
Thanks.
If you enjoyed this episode, make sure you subscribe to our channels. Episodes will be posted once a month with a variety of industry leaders, and you can follow us on LinkedIn, Twitter, and Facebook as a Garajan. Have a good one.